Good evening, everyone. Today, my topic of presentation is regarding a study to determine the current role of donor corneal rim microbiological analysis in corneal transplantation. Donor corneal contamination can occur due to prolonged hospital stay, different procurement and preservation techniques, and pathogenic ocular flora. However, the risk of donor to host microbial transmission is 12 to 22 times greater with a positive donor corneal rim culture, and this is especially so in case of contamination with fungi or gram-negative bacteria. So we should keep this in mind because post-keratoplasty infections are rare but devastating. So the question arises about performing the DCR culture. Is it cost-effective? Does it correlate with post-transplant infection? But can it help with early diagnosis and treatment of post-transplant infection? And can we also start prophylaxis based on the DCR culture sensitivity? So the aim of this study is to analyze the donor corneal rim culture in patients undergoing optical keratoplasty to determine the significance in the incidence of post-op infections. Our objectives include assessing the donor characteristics, incidence of post-keratoplasty infections in case of a positive DCR, and evaluating the utility of the DCR culture. It's a retrospective study which was done between Jan to March 24, wherein 60 donor corneal rims from 35 donors were analyzed, and we looked at the donor characteristics and the DCR culture parameters. Coming to the results, in our study, most of the donors were in the 7th decade, mostly older donors. The death to retrieval time was around 3.6 hours. The most common risk factor was diabetes, and the retrieval to transplant time was around 5 days. The most common cause of death we found was cardiac death, and we saw that a prolonged hospital stay was seen in 12 patients, wherein a positive DCR was only in 2 of those patients with a prolonged hospital stay. The culture positivity was relatively low with 23%, and mostly were bacteria, 64.3%. So the organisms grew on 14 donor corneal rims, of which 9 were bacteria, 3 notably were virulent, and 5 were fungi. It is interesting to note that only 1 pair of eyes collected from the same donor had a positive DCR culture in both eyes with different organisms in each DCR. It was a diabetic donor, and neither eye in the host developed a post-keratoplasty infection. So these are the risk factors that we looked at. Firstly, a prolonged hospital stay, which was only in 2 donors. Place of collection, almost similar statistics, 5 and 8 donors. And diabetes in the donor in 5 donors. And we also grouped the organisms as virulent and gram-negative, wherein the risk factor was a prolonged hospital stay, and they were given prophylaxis with topical fluoroquinolones post-operatively. And in the second group of fungi, the donors had diabetes, and we also gave natamycin prophylaxis post-op since the patients were also single-eyed. Coming to the discussion, we have also seen, as per the review of literature, that diabetes is a risk factor associated with a positive DCR. And we see across the studies that the incidence of post-keratoplasty infection is relatively low. And like our study, post-op antibiotics were provided in most studies, but antifungals were started only if there was an infiltrate observed. So is this prophylaxis really useful? Yes, it can be useful, as shown in some studies with DCR positive for GNB and some studies with DCR positive for Candida. So these are the recommendations of this study. Periodically review the DCR culture report, monitor and follow up the patients with a positive DCR, review the DCR culture report from the pair of the single donor, then provide antibiotic prophylaxis, especially in case of single-eyed patients or if there's a virulent organism on the DCR. Also, we can store the DCR in a media and analyze only if there is a post-transplant infection. In conclusion, the donor tissue needs to be harvested and used as soon as possible. Early diagnosis and treatment based on the DCR is useful, and antimicrobial prophylaxis is very useful, especially in a DCR positive for gram-negative bacteria and fungi or in a single-eyed patient, and close follow-up of patients with a positive DCR is necessary. Thank you.